And as women, we go through so much that many people don't know, not even our closest community. And we fight so many unseen battles and still have the strength to endure all the hardship that comes our way. And I want people to know my story because it is very important to understand that the smile that you see on my face sometimes has so much pain, struggle, worry, and strength behind it. And usually what meets the eye is not all there is. So while I went through my experience, I received a lot of judgment, a lot of mean words, heard a lot of gossip. Welcome to the show. I am your host, Anya Fombat, and I spark the hard conversations that challenge questionable cultural and societal norms that threaten the well-being of the African community. And I also share stories about growing up as Africans in Africa and in the diaspora. I strongly believe that normalizing open discussions and sharing experiences, whether good or bad, will not only make you find your voice, but will broaden your sense of purpose and empower others to do the same. So if you have ever tried challenging certain African cultural and societal doctrines, or if you have ever felt like it is about time that we confronted these issues in our African community and do better as a people, or even if you have always been interested in learning about the experiences of other Africans growing up in Africa and the diaspora, then you are in the right place. Welcome to Living African. Hello everyone, Happy New Year and welcome to another episode of Living African. So today I will be talking about a very personal topic and I will get a little bit vulnerable with you guys, which I really don't like doing, but that's the whole point of my podcast. So I will be sharing a personal story with you guys because I feel like if I am creating this platform for us to share our stories and the things that are being pushed under the rug, it only serves the right purpose for me to do the same. So I decided to share my story because I strongly believe that many women can relate to my experience as well as my fears as a woman, as a young African woman actually. And as women, we go through so much that many people don't know, not even our closest community. And we fight so many unseen battles and still have the strength to endure all the hardship that comes our way. And I want people to know my story because it is very important to understand that the smile that you see on my face sometimes has so much pain, struggle, worry, and strength behind it. And usually what meets the eye is not all there is. So while I went through my experience, I received a lot of judgment, a lot of mean words, heard a lot of gossip, and even some family members told me that I was testing God by not having children when they wanted, I guess. But that shouldn't be our focus for today. My story is exclusive to me and my experiences have made me who I am today, and I am extremely grateful for the journey I have had so far. And I also have here with me my OBGYN, Dr. Ekwo, who has been here before, and we spoke about the infertility episode with her, and she's here with me to provide scientific insight and advice to certain parts of my story. And this is for the main purpose of, enabling other women to fully understand certain things pertaining to their own experience and also know what exactly to expect or demand from their health provider if they have the same experience. So to every woman out there, you may have a different story than my story, but I really hope that we can relate somehow and be more open to sharing our experiences with one another. And most importantly, I really hope that we can learn to be more kind and show empathy to one another because we are all fighting battles that nobody knows about. So here's how the story goes. In 2015, I found out I was unexpectedly pregnant. So it definitely wasn't planned. It was truly a time of my life where I was making so many transitions. I just graduated from pharmacy school, starting to take my board exams. I just had a new job in a different state. And, the last thing that came to mind was for me to be pregnant. But hey, I got pregnant. So how I found out was really funny because I started complaining of, severe pain on my lower right side of my abdomen, which is also called the right lower quadrant. And I never felt that kind of pain before. So I decided to go see a OBGYN, a doctor specializing in women's health. And I actually had a history of ovarian cysts. So when I saw the doctor, I consulted with her and she recommended that I go on birth control pills, which actually has been proven to help with the cysts. But then before that, she suggested that I do a pregnancy test just to make sure I wasn't pregnant, because if I was pregnant, then there's no need to be on birth control pills, which also prevent pregnancy. So I did the test and it came out positive, and I was actually in utter shock. I mean, I was literally going through so much in my life with school and my exams and every other thing. And the last thing that I was really ready for was to start a family. So I was pretty devastated. So I eventually moved to the new state, and which was about an hour and a half away. And I eventually followed up still with that same OBGYN. So I drove back and forth to see her, and I did a couple of scans and ultrasounds, and they discovered that I was pregnant. I wasn't only pregnant with one baby, but with two babies. So I was pregnant with twins, but as if that wasn't enough, I had a mono pregnancy, which mono just basically means monochorionic pregnancy, which Dr. Ekwo, who's here, will definitely talk about that. But this is a rare type of pregnancy, and it has been shown to occur in less than 0.1% of all pregnancies. So to say that my world came crashing down is definitely an understatement. I wasn't sure if I was ready for two babies, but that wasn't as scary as the high-risk pregnancy that I was about to experience. So it was such a very difficult time for me. And considering all the risk involved, it was very, very important for me to have an OBGYN who was closer to me instead of me driving an hour and a half, 2 hours away to see the old OBGYN. But another problem that I ran into was that no OBGYN wanted to take me as their patient because of the high-risk pregnancy that I had. So all of these things were very shocking for me to learn about. And that's why when I was reflecting on this journey, and I really wanted to share this journey with you guys, I wanted to bring in someone who has a lot of expertise in women's health and in issues like this to really give insight and answer some of the questions that you may have had at the back of your mind after hearing my story so far. And that's why I had Dr. Ekwo come in here. So I just want to welcome you here again, Dr. Ekwo. And I thank you for taking the time to speak with me on this very sensitive topic and personal topic. So I just want to welcome you again to the platform. How are you doing today?
Thank you. I'm doing well, actually. Thank you. And again, I'm Dr. Temitope Ekwo, board certified OBGYN. I practice in the medical center in Houston, Texas, at the Women's Hospital of Texas.
Thank you. So we're just going to dive into a few things that I mentioned in my story. I just want to give our listeners scientific definitions of a few things. So I'm just going to start. I had mentioned that I had a history of ovarian cysts. So what exactly are ovarian cysts? How common are they, and how do they affect pregnancy or fertility?
So our ovaries are where our eggs are harbored. And so an ovarian cyst literally just means you have. So people think cysts are bad things, but backstory is that we, as ovulating women, create cysts on our ovaries every month because that's where we ovulate from. So a cyst is just where the ovary has created a small sac within the ovary that's typically fluid filled. And when it's an ovulatory or follicular cyst, it harbors a very small egg within the cyst wall. And so each month around, halfway through your cycle, most women, it's about 14 days after the first day of menses, you ovulate, which is when the cyst ruptures and secretes the egg in an attempt to allow you to conceive. So there's many different kinds of cysts. Most are benign. Some can be precancerous or cancerous, but most of the time in young ovulating women, they're just follicular cysts that each month resolve. If you don't get pregnant and another cyst is recreated from month to month, that's the normal cycle for a premenopausal woman, which is what we're discussing here. You can get, nitty gritty and talk about all the different possible cysts that a woman can make on her ovaries, but that is beyond the scope of this conversation. Right. So at the end of the day, I tell my patients all the time, cysts on your ovaries are normal because that's typically where you ovulate from. If you ovulate and don't get pregnant, the cyst resolves and a new one reappears the next month. Right. So Obviously, if you're ovulating from month to month, that kind of cyst is not affecting your fertility. Kind of cysts that can affect your fertility are cysts that are due to other causes, which can typically don't resolve on their own and then require some kind of ovarian surgery. So if you have to have some kind of surgery on your ovary, of course, it diminishes the amount of eggs you have. And that's how that can affect fertility, which, like I said, a lot of that is beyond the scope of this conversation. Right. So long story short, when a person is told that they have cysts on their ovaries, you really have to dive deep and ask your provider what kind of cyst, because most of the time it's just a normal follicular cyst where you ovulate from month to month.
Okay. Thank you very much for sharing that.
You're welcome.
And I mentioned that, when I found out I had the twin pregnancy, it was they also said it was a mono pregnancy. So can you please explain what that is and, the risk associated with it and, if it can be avoided, just everything, just a holistic overview of what a mono pregnancy is. So
monochorionic, monoamniotic twin pregnancy. So you have several different types of pregnancies where people say, fraternal twins versus identical twins, which is not really medical terminology. There's two different ways twin pregnancies can be created. So 2 eggs fertilized by 2 different sperms. Those are typically what people refer to as fraternal twins because they're twins, but they don't look alike. So those are the twins that can be a 2 boy and a girl, or 2 girls or 2 boys, but they're not identical. A mono twin means that 1 egg was fertilized by 1 sperm, and then usually about day 3 to 7, somewhere about there, that's when that fertilized egg splits into 2. And so that's how you see those twins, that they look identical because they have the exact same genetic makeup because it was 1 egg fertilized by 1 sperm and they split very soon after development. And so you can see that lots of issues can arise with mono twins because what it means is that they share a placenta and they share a amniotic sac. And so what an amniotic sac is, what layman terms people refer to as my bag of water. Yeah. So these twins are in the same quote unquote bag of water and they share the exact same placenta. They just have their own umbilical cords coming off of the same placenta versus the other type of twins where they have their own placenta and own sac. So literally 2 separate pregnancies just at the exact same time in the womb. So the reason mono twins are very high risk, and you won't see very many generalist OBGYNs such as myself take care of them because they have lots of risk associated with those pregnancies, and not just risk to baby, but risk to mom. So some of the risk to the babies, and I'm going to throw out these terms, but it's not to boggle you down with these terms. They're just to kind of really go into why it is that they're so high risk. And people say, oh, I want identical twins, but a lot of times they don't realize what goes behind the scenes of taking care of these identical twins. So there's one, the biggest concern is what we call twin transfusion syndrome. And that's where one of the twins starts essentially taking all of the nutrients from the other twin. And so you have one twin that is bigger and fatter than the other twin, which is much skinnier and is lacking blood supply because they have blood vessels that in the placenta are going between the 2 of them, and it's shunting more of the nutrients to one twin. And so that's very, very high risk kind of issue that happens mostly in mono. It can't happen in di twins because they don't share a placenta. So it happens in mono twins. A lot of times it can lead to fetal demise of one or both of the twins. Then there is another one where it's called TAPS. So twin anemia polycythemia sequence. So when one of the twins is anemic, whereas the other twin gets, again, most of the nutrients of the pregnancy. Because of you can have cord entanglement because, they both of their umbilical cords are in the same amniotic sac. So one of the twins, unfortunately, can get tangled in the cord, which can lead to fetal demise. Yeah. You can have fetal demise of one twin, which can cause fetal demise of the other twin. You can have congenital anomalies of one or both of the twins. So those are just a few of the fetal risk of mono twins. And then when it comes to maternal complications, you can have gestational hypertension, which is high blood pressure caused by the pregnancy. So you can have gestational hypertension or preeclampsia. The mother can have gestational diabetes as well. So as you can see, these kind of pregnancies come with so many potential risk factors that most generalists aren't going to take care of these pregnancies, because you need to be at a center that is able, if issues arise, to treat and manage these pregnancies. And typically mono twins don't go to term. Most of the time they're delivered between 32 and 34 weeks.
Wow. Well, thank you so much for sharing that. And while you were talking, it just got me thinking, is that also how conjoined twins could potentially be formed, through the mono?
Yeah, so it's a pathway, and day of fertilization is day 0. And so depending on when the egg that is fertilized by one sperm, when it separates, that's what determines whether it's a mono pregnancy or a conjoined pregnancy. And I believe so like I said, for mono, it's typically after about day 9, if I remember correctly. If they separate after day 9, that is what results in conjoined twins.
Interesting. Thank you very much. This is really the first time that I have really had that scientific explanation, in depth, about what kind of risk I could potentially be in, because at that time I just cannot understand why. Because when I moved to my new environment, I called every single OBGYN around there, and not a single person wanted to take me, and I mean, all I knew was that there was a high risk of me having a miscarriage as well, in the early weeks of the pregnancies. That's why I really wanted to get someone who was closer to me that I could go see, at any time and stuff like that. So now that you have explained it, it kind of gives me better insight at the kind of risk that my life was in, and also the risk that, my babies at that time were in. So, considering, like I mentioned, considering every other thing that was going on with the hecticness of my life, it wasn't really long before I started feeling so much pain in my lower abdomen that I think it was about a week.
And sorry, I just wanted to clarify, I'm just very anal and don't want to spread misinformation. So when it comes to separation, there are 4 types of twins. There's di-di, mono, and conjoined. And so di twins, typically they separate at day 1 to 3 after fertilization. Mono separates day 4 to 8. Mono is day 8 to 13. And then conjoined twins is if they separate after day 13.
Okay.
So I just wanted to clarify that for everyone listening, that there are 4 types of twins, and it depends on when they separate after fertilization will determine what type of twins they are.
Okay. Thank you very much.
Sure.
Yeah. So as I was saying, it wasn't before long until I started feeling so much pain in my lower abdomen, and that was about week. I think that should have been almost week 12. And that's when I really started realizing that I was bleeding heavily. Now, the first thing I did was I went to the ER. I rushed to the ER, and they diagnosed me with an incomplete miscarriage, which basically meant that the first baby had passed on and out of me. And the second baby, they could still get a heartbeat. So the second baby was still alive. And then they sent me home, but I didn't stop bleeding. So I went back home and I was still bleeding. I was hoping that, I would stop bleeding by maybe the end of the next day or by the next day. And so by the next day, I actually bled so much that, I could not even stand up. My heart rate just went up all the way. I mean, the normal heart rate is from 60 to 100 beats per minute, but mine was way higher than 100 beats per minute. Whenever I stood up, I was just so dizzy. I couldn't even do anything. I literally spent most of my day in the toilet because I started bleeding so bad. I couldn't even, the blood could not even contain, the pad that I was wearing could not contain the blood that was oozing out of my body. So, I mean, I was rushed to the ER again, and then they discovered that the second baby had passed on out, but I still kept bleeding. They gave me some fluids and then sent me home again without stabilizing me. So at this point, I personally knew that something was not right because I wasn't supposed to keep bleeding that way. They had to have at least helped me to stop the bleeding. And even when I insisted, but nobody just wanted to hear what I had to say, they just sent me back home. So by the fourth day, I had lost so much blood that I had to be taken back to the ER. This was all within 1 week. So I went to the ER 3 times. And by this time, it's like I lost so much blood that they measured my hemoglobin level and it was about 7. Now for women, the normal range is about 12 to 15.5. So I had lost so much blood and I had to be given 2 bags of blood. And then that's when they made the decision to take me for dilation and curettage surgery, which is the DNC surgery. And that actually finally stopped the bleeding. Now, I just want to bring you back in, Dr. Ekwo, so we can, of course, explain a few things that I just said. So what are classic signs and symptoms of a miscarriage, and when should women, check with a doctor or go to the ER during pregnancy if they have certain symptoms that could potentially signify a miscarriage?
Typically, the signs and symptoms of a miscarriage are exactly what you had. Lower abdominal pain, feels like severe menstrual cramps, in addition to heavy, bright red vaginal bleeding like a cycle. So a lot of people are unaware that you can have a little bit of spotting at points in time in pregnancy. That could just be due to irritation of the cervix or what we call postcoital bleeding. So bleeding after intercourse, just due to how vascular the cervix is. So if it's just spotting or light bleeding, typically that's not a sign of miscarriage. But heavy, bright red bleeding like a cycle, in addition to severe pelvic pain or cramping, those are the signs of a possible miscarriage, which you should be concerned and call your doctor or go to the emergency room.
Right. Thank you. So talking about the emergency room, now I had asked a few people, why I was being sent home all the time when I wasn't stable. Some people were for the decision of the hospital. Some people were against. Some people said, sometimes they send you back home because, especially if it's a twin pregnancy, it's like eventually the bleeding typically stops. So they don't have to, it's hard for them to determine what stability is at that point. They want to see how much more you bleed, but then again, you just can't sleep in the ER. You have to go home. But other people said they did not have to send me back home until they made sure that I stopped bleeding. So what was your opinion on that and why I was being sent home, and if that was even the right thing to do, just to help patients in the future to be their own advocate if something like that happens?
So I don't like to say if it was the right thing to do or the wrong thing to do because I wasn't there. Right. I didn't have your chart. I didn't evaluate you. I don't know how heavy your bleeding was, what other things that were included in that physician's decision making. So I'm going on the record. I can't say if it was right or if it was wrong. But what I can say is that typically, yes, with twin pregnancies, sometimes not as likely as in a mono pregnancy, because like I said, same sac, same placenta, but more likely in a pregnancy where they have their own sac and own placenta, you can unfortunately have a miscarriage of one twin and take the other twin to full term. And so when you tell me your story, my inclination is that maybe they weren't aware of what kind of twin pregnancy it was in fact. And they were thinking, oh, okay, maybe you miscarried the first twin with hopes of you being able to your cervix reconstituting. So your cervix going back to close in an attempt and hopefully carrying the other twin to term so that you essentially hoping that miscarriage stops itself. But again, I wasn't there. I don't know what information they had and why they were making the decisions they were making.
Right. So now I talked about the DNC surgery as well, which is, was typically done to stop the bleeding. But how will you define a DNC surgery and what are the benefits or risks associated with that?
So a DNC is, like you said, it's a dilation and curettage, typically treatment of what's called an incomplete abortion. And when we say abortion, that is the medical terminology for miscarriage. And so an incomplete abortion is where your body has started to miscarry, but for some reason it hasn't completed the process. So your cervix is dilated, and you're bleeding heavily. So incomplete abortions are a medical emergency where typically have to take a patient to the operating room to assist in the completion of emptying out the uterus. In your issue, however, you said that twin B still had a heartbeat. So it puts physicians in a very difficult predicament because if you do a DNC on a fetus that is still alive, that is you essentially performing an elective abortion, which is what people know as abortion. So let's just, comment on your situation is kind of it's very, like you said, is not very common, but again, most incomplete abortions, that's how we treat them, because if you leave the mom and their cervix is dilated, they're bleeding, they could bleed to death. Other reasons we do a DNC is if a woman has what's called a missed abortion. So they just come to the clinic, for their routine prenatal visit. You go to get heart tones and you realize that the baby's no longer has fetal cardiac activity. So at that point, they're not having any signs of a miscarriage, no bleeding, no pain, their cervix is closed. You can offer them to give their body time to see if their body will do it on their own. You can give them the option for medication to induce their body into a miscarriage, or some people would prefer just to get it done over and done with. And those are the people that opt to go for a DNC. At the end of the day, there's risk with each of them. If you take the medication, granted, the pros are you don't have to be put to sleep. You don't have to undergo a surgery, but you run the risk of the medication not working, or it working but incompletely working, where you'd end up having to have a DNC. The risk of a DNC is it is surgery. It's major surgery where you have to be put to sleep. There's the potential risk of poking a hole in your uterus during the procedure because your uterus is very thin at that point. And so if you're not careful, you can poke a hole in the uterus, or some people could be so aggressive during the DNC that it could cause scar tissue, which could affect future pregnancies. But the benefits are you are put to sleep. You don't have to go through that process and deal with it, deal with the pain and the bleeding at home. So there are risks and benefits of each procedure. Right.
Thank you very much for sharing that. And that's very great information, and hopefully we will touch back on this, down the line within my story. Now, obviously this entire experience was extremely traumatizing for me, and it actually made me terrified to get pregnant again. Honestly, I was just like, I really don't want to have to go through such an experience, but then it wasn't until about last year when my husband and I decided that, we wanted to try to get pregnant again. But however, it suddenly became very challenging, which was very surprising to me, because considering how easy it was for me to get pregnant before, I was really shocked. I was like, I thought it was very easy for me to get pregnant. I thought I was very fertile. I got pregnant with twins when I didn't even want to. But then again, after having had the conversation with you and Dr. Plenty on the infertility series, I now have more insight in hindsight to know that just because you get pregnant once, it doesn't mean that you can get pregnant again. There's something like secondary infertility. So now another thing that really bothered me was that, in the 2 episodes ago when my family and I sat down to talk about my brother who was a special needs child, the issues and the trauma that my family went through with him, it also kind of made me nervous about having children as well, because I always had this thing at the back of my mind, like, what if I have a child and the child goes through what my brother went through, So those were one of the fears that I was battling with internally. So, but then even though we were trying to get pregnant, I still, had these fears at the back of my mind, and about whether my baby would be healthy, and especially considering, the mono pregnancy that I had had in the past. So we still went ahead and tried, We enjoyed the process while it lasted until I decided, to see you. And that's how I even came about meeting you. And that was probably one of the best decisions ever. So we met you, and so that was early 2021. And, I told you of our journey and everything, trying to conceive, and you told us about, getting an HSG. That was the very first time I heard the word HSG. I had no idea, and that was basically to see if there was any obstruction in my fallopian tubes. And so when I did the HSG and I did the procedure, and the results came back indicating that, both my tubes were blocked, and there was really no cause as to why. I mean, being the inquisitive person that I am, I did all kinds of research. I asked all kinds of questions like, what are the possible, causes? But at that point, nothing was really set on fine print as to why, it wasn't like a scar tissue or adhesions or nothing, at least to my understanding at that point, and based on my conversation with you, you had referred me to, a fertility clinic to go see a fertility doctor. And then you also ordered my husband to do a semen analysis. And so his semen analysis came back normal, and the fertility doctor's advice was for me to do like an operative hysteroscopy, which basically was to confirm the HSG results. As she said, sometimes, when they do the first HSG, sometimes it could be a false positive. And also if there was any confirmation, then if there were any issues, then that operative hysteroscopy could also correct any issues that could be found in the tube, like flush it out or whatever. And then if it still doesn't help, then that's when she recommended that we could potentially do an IVF. So, I mean, at that point, Google and every kind of health portal or health resource online was my best friend. I did all kinds of research and tapped into all kinds of resources, which probably wasn't the best idea. But I mean, being a health professional, I knew what to take and what not to take, at least to the best of my knowledge. But then I know that, ectopic pregnancy could potentially happen, especially in people who have blocked tubes. So that was my greatest fear, because I was like, yeah, even if they do the operative hysteroscopy, now, what if I conceive and I have an ectopic pregnancy? I actually know 2 people who had ectopic pregnancies and they died, so that was another fear of mine, and I was super terrified, so it made me really nervous. And I just told the fertility doctor, I told her, I was like, you know what? I don't care what the outcome of this hysteroscopy is. I just want to do an IVF. I mean, my husband and I already spoke about that, and we were ready to go forth with an IVF, so that's where we made the decision to now start planning the IVF, which we will go further into. But I just want to back up a little bit and let you give a little bit more insight about certain terms that I, mentioned. Like, I'm going to start first with, the HSG, like what actually is an HSG and when is it recommended?
So HSG means a hysterosalpingogram, and that essentially is an X-ray of the uterus that is performed at the same time that dye is being injected through the cervix into the uterus. And so HSGs are part of an infertility workup. So when someone comes in, says they've been trying for X amount of months and unable to get pregnant, and like we discussed last time, infertility is inability to conceive for 12 months in someone less than 35 or 6 months in someone greater than 35. And so infertility workup includes a semen analysis for the man to ensure that he actually is creating sperm, make sure the sperm is normal, make sure the sperm is mobile. So that's called motility. Make sure that he doesn't have low sperm count, because just because you ejaculate does not mean you have a sperm in your semen. So that's the male's part. And then the female part, we have lots of different things that go into being able to conceive. So you want to make sure your ovaries are actually in fact working and you're ovulating from month to month. And we have blood tests for that. Then you want to look at the uterus, typically using an ultrasound to make sure you don't have any fibroids or anything that is making your uterus anatomically abnormal. And then the HSG is to look at the cavity. So to make sure the inside of the uterus is shaped normally, and make sure that the tubes are open, because the tubes need to be patent in order for the egg to meet the sperm. So that's where the HSG comes into play. And like you said, yes, tubal occlusion. So when you have blocked tubes on the HSG, it will appear on the X-ray that dye does not go through the tubes. And that can be caused by many different things. A person can have tubal spasm so irritation of the fallopian tube at the time the dye is being injected, so that on x-ray or on the imaging will appear as the tubes are occluded. Or it can be that there's an obstruction, so something that's blocking the tubes, but it's not actually that the tubes aren't patent. Or you could in fact have actual tubal occlusion where both tubes are in fact blocked because of, typically it can be because of fluid or be from previous infection. So there's many reasons that someone could have tubal occlusion on an HSG.
Right. And actually, I had both my tubes were actually blocked, which, was definitely traumatizing because I know some women, you don't need both tubes to be open to be able to conceive, right? You can also conceive if you have one tube open, but for me, it was both tubes that were blocked, which is pretty devastating to learn, So now, what is an operative hysteroscopy and how different is that from a diagnostic hysteroscopy?
So hysteroscopy, for those who don't know, is where you go. It can be done in the clinic or out in outpatient surgery center or in the operating room, where you go in through the cervix with a camera and you look at the inside of the uterus. So diagnostic just means you're just going in, you're looking, taking pictures, you're not doing anything, and you're coming out. An operative hysteroscopy is the exact same thing. You're using the same kind of camera. You're going in through the cervix, looking at the uterus, but you're actually doing something. You're performing some kind of procedure, whether it be removing a polyp, removing fibroids. So that's the only difference. Is diagnostic, you're just looking, taking pictures. Operative, you're actually performing some kind of procedure.
Okay, thank you very much. And now I mentioned one of my greatest fears, which was potentially having an ectopic pregnancy. So what is that, and what are the signs and symptoms and the risk factors, and when should women really be concerned about that?
So an ectopic pregnancy is any pregnancy that is located outside of the uterus. So there's many types of ectopic pregnancies. It can be located in the fallopian tubes, in the ovaries, in the abdomen, in the liver. They're very rare.
Liver?
Yeah. Mm-hmm.
Wow.
Absolutely. Yeah.
How did egg find its way there?
Exactly. Who knows? How did the egg and the sperm find their way there? But yes, absolutely random. They had an episode of that on Grey's Anatomy. Someone who had a liver ectopic, and it, in fact, it's possible. It's very rare, but it is possible. But risk factors for an ectopic pregnancy are people who've A, had an ectopic pregnancy in the past, or B, have some kind of scarring in their fallopian tubes. But a lot of times it's a spontaneous thing that ectopic pregnancies happen. And it goes back to signs and symptoms are pain. So if you start having severe pain, and it could be your left or your right side. Like I said, the ectopics can be in multiple places. So sometimes the pain can be really vague. You're having pain and they can't figure out why. And, when you go to the emergency room, they should, on all menstruating women, do a pregnancy test. But typically how ectopics are found are you go in for some pain or some irregular bleeding. They do a pregnancy test. They find out you're pregnant. Then they do an ultrasound and they notice that there's no pregnancy in the uterus, but you are, in fact, have a positive pregnancy test. That is typically the number one inclination that someone has an ectopic pregnancy.
Right. Thank you very much. And so I mentioned that my husband and I opted to go for an IVF procedure. Can you just quickly tell us what that is and when it is advised? And also, why is there still a stigma surrounding IVF procedures? And why do women really shy away from doing it or just talking about it, especially in our African community?
So IVF is atrial fertilization, where it means that you take the egg and take the egg from the woman, you take the sperm from the man in a dish, you fertilize the egg, you allow it to develop for a certain amount of days before you now re-implant it into the woman's womb. The reason for, in your case, that was recommended was that's the only way to bypass the tubes. Because if the tubes are blocked, like I said previously, there's no way for the egg and the sperm to meet. So you have to essentially force them to meet outside of the body and then put them back. IVF is part of the assisted reproductive technology. I can't say who it's more beneficial for than who it isn't. Mm-hmm. And the reason is because there's many different reasons someone might opt for IVF. In a situation where both tubes are blocked, well, IVF is the only option. But some people, some people who are dealing with infertility for other reasons have tried other forms of assisted reproductive technology, which didn't work for them. And so their last resort is IVF. So IVF, it really is patient-based, depending on the cause of infertility.
Mm-hmm. All right. Thank you very much. So, talking about the IVF again and my whole story with the hysteroscopy, we went on to set a date for that hysteroscopy, and that was basically the same day where I was going to start my medications to start the IVF process, because I really wanted to start that as soon as possible since it took a couple of months. And so the doctor had told me that, it was supposed to be the start of my next menstrual cycle, which is basically day one of my next period. And, this whole experience was just pretty devastating. And, I don't know if I had ever felt that much stress and anxiety, especially with the uncertainty of everything. But I really tried to just focus on myself. Of course, I still went to, Dr. Google, Dr. WebMD, all those websites. But then again, I tried to build my relationship with God. I just was very, very, that's what I really built a close relationship with God. And I was very prayerful. I tried to, relax and not let whatever was happening around me, come into me. I mean, my husband and I actually decided that we will not let our life stop because of our circumstances, and we decided to just do things that brought us even close together. And we continued our journey of trying to conceive. So my period actually had to come on the first week of April, and that was also when I had made an appointment to go to the fertility clinic, but my period did not come. And if there's one thing in my life that's constant, it's my period. Like, my period has never ever come late. It has never, ever not come on time. It always comes either 1 or 2 days early, or it comes on time, never, ever late. So this kind of got me a bit worried. And, I waited another day and nothing came. And then I had purchased some pregnancy test strips and tested to see if I was pregnant. On those strips, a double line meant that I was pregnant and a single line meant that I wasn't pregnant. So for some reason, the strips just did not have a double line, or just maybe because I was not as patient enough, because by the time he had 2 lines, supposedly I had thrown it in the trash. So that evening I was still worried, and I decided to, take another test again. But this time I was really, really patient. And then, I waited, and then this time it didn't even take much long for the 2 lines to show up. And so I was like, I could be pregnant. I started thinking. So I went to the pharmacy, purchased an electronic pregnancy test, and I repeated a test, and I was actually pregnant, and my husband and I, we were very shocked, though we were excited, and we knew that then and there that it was nothing short of a miracle. And, I remember coming to see you again. I actually called your office, and they were like, interesting. I was like, yeah, I'm pregnant. I am not going back to the fertility clinic, and I canceled my appointment with them as well. And, it was really something that I have been bugging myself and asking, like, what must have gone on? But it was something that, one of those things that cannot be explained. I know when I was doing some research on Google, they had mentioned that, a very low percentage of women, when they have the HSG, as you had mentioned, is a dye that's inserted into the tube. Sometimes when the dye is coming out, it flushes, whatever obstruction there is in the tube. So I'm thinking maybe that, is what must have happened, or that was just a miracle, So this was basically the start of my pregnancy journey up to now. And by the time this episode is aired out, I'm very sure that the little mama will probably be a month old by then, but I just had some few questions regarding this experience. I really wanted us to now talk about my pregnancy journey so far. I personally did not have the regular symptoms of nausea or hyperemesis gravidum, which is the severe vomiting. Is really not, should not be a normal or expected symptom. But what I really had the most was like the ligament or groin pain. My goodness, that has been a consistent experience throughout my pregnancy, and also with the random bleeding, which was basically very light bleeding at the start, which kind of scared me. But do you mind just giving some insight on that pain that, I've been having, and, and also maybe potentially uncommon symptoms in pregnancy?
So round ligament pain is lower abdominal pain. Lower back pain is something that's quite common as the pregnancy progresses, typically more so in the second trimester, around like 20-ish weeks. And it's because the two round ligaments, they're like suspenders that hold the uterus in place. And so as your uterus starts to grow out of the pelvis towards the belly button, those ligaments are put on tension, which is what causes the round ligament pain. Some people have it more severe than others, but at the end of the day, it is a very common symptom during pregnancy. Like I said, some have it more severe than others. Some people need to have like pelvic physical therapy during their pregnancy to help with that pain and discomfort. Myself, I've had to have pelvic physical therapy this pregnancy, which I haven't had to have in other pregnancies due to round ligament pain, pubic symphysis dysfunction. All of that is part of the growing your body does and the pelvis does as baby is growing to accommodate the pregnancy. And so typical symptoms that people experience during pregnancy in the first trimester, it can be nausea, vomiting, breast tenderness, food aversion, which some people, they have food aversion to the point where they do lose weight. And a lot of times patients think it's concerning that they've lost weight in the first trimester. So it depends on how much weight you're losing and also how much vomiting you're doing, which determines is it normal or is it abnormal. In the second trimester, it's more just kind of the discomforts that we discussed. Third trimester, your appetite typically comes back in the second trimester. The nausea, the vomiting gets better. Your appetite comes back. You start to gain weight. Third trimester, a lot of times it's just the discomfort from the weight of the baby. So it can be the pelvic pressure, pelvic pain, lower back pain, obviously reflux because the pregnancy is now pushing on the stomach. So it makes it more difficult for your food to digest, or for you to eat large meals. And if you force yourself to eat large meals, it doesn't digest as quickly, which leads to reflux. Some people can have shortness of breath when they're exerting themselves. So there's everyone's pregnancy is different. So I could talk for years about all the different symptoms that people have. But at the end of the day, if it's something that's concerning to you, always bring it up to your doctor so that they can determine whether it is a normal symptom of pregnancy or if it's something that needs to be investigated further.
Thank you. So during this pregnancy experience, oh my God, I don't think I've ever been poked as many times as I have throughout this journey. I mean, I'm literally immune to just the pokes, and I know, our audience for this podcast is primarily in Africa, or at least to the Africans. And there are a lot of areas that have a huge lack of healthcare resources, especially for pregnant women. So, and they may not be able to accommodate all the intense exams and tests that we have the privilege of having here in America. So if there was maybe 3 or 4 top main checkups that you would advise for a woman to have during pregnancy, what will they be?
It would be the initial checkup where you get the ultrasound to solidify your due date, because, sometimes your due date does not align with the one that is estimated from your last menstrual period. So the first appointment where you get your ultrasound and get your initial prenatal labs. And that is very important because your initial prenatal labs, we're checking for HIV, hepatitis B, hepatitis C, syphilis, checking for anemia, checking for sickle cell trait, checking for your blood type. All of those are very important because those results could weigh heavily on how your pregnancy outcomes. So that appointment is very important. Of course, we do appointments typically between 18 to 20 weeks, which is for the anatomy scan. That's very important. Yes, some places they might not have access to this, but if you do, it's important. And that's not a gender scan where you're like, ooh, let me find out the gender. It's looking at all of the baby's organs to make sure everything is developing appropriately, making sure there's no anomalies, because again, that can have significant bearing on the pregnancy. The next appointment, so that's the second appointment that is very important. The third appointment that I would say is very important is where you get screened for gestational diabetes, because some people, diabetes does not show up until you're pregnant. And then and then of course you want to make sure you're seen closer to term, make sure baby's growing appropriately, make sure your blood pressures are normal, make sure everything is just progressing as we want it to.
Right.
But very important are those 3 appointments that I mentioned. Those are very important not to miss. And then, of course, it really depends on your person's pregnancy. Are there any other complications they're dealing with? That will determine how frequently they're seen and what other appointments are very important for them not to miss.
Right. Thank you very much. So right now I am actually 9 months and I'm very, very close to my due date, less than a month away. And, the C-section versus vaginal delivery is one of the most important decisions to make. And so I just want to know what your thoughts are on both methods of delivery. And, in our community, it's especially our mothers, they believe, they did it vaginally, so we have no right to do it via C-section or whatever, even though C-section could come into place as a very huge necessity depending on the risk, that the mother or baby are in. But what do you think about both? And why do you think there's still so much bias against C-sections in our communities?
So at the end of the day, I can't tell you a C-section is better than a vaginal delivery or vice versa, because again, that goes to patient by patient basis. In some patients, there's no option for vaginal delivery because it's not safe for the mom or the baby. So going back to your story, in a patient who had mono twins, if those were taken to term, you're not going to find anyone that's going to give you the option for a vaginal delivery because it's highly risky for the infants. But at the end of the day, like I said, both are safe and both are effective forms of bringing babies into this world, rather. It just depends on the patient's background and the pregnancy history, which determines which route is safer. Personally, I've had 2 C-sections and I'm scheduled for my next C-section in a few weeks, and no one can tell me that I should have had a vaginal delivery with my daughter because my daughter was breech. And so there was no way I would ever put my child through the potential harm of having a vaginal delivery just to say I had a vaginal delivery, knowing that breech deliveries, 9 times out of 10 babies do not make it through. Right. And so I tell my personal story to say that it's on a case-by-case basis. I think there's a stigma surrounding C-sections because of lack of education. And unfortunately, some of the very educated people still have something to say about C-sections, but then that goes back to lack of knowledge when it comes to obstetrics. Because if you had the knowledge necessary to realize that some scenarios, a vaginal delivery is much riskier to the mom and to the baby, they'd realize that C-sections, vaginal deliveries, as long as mom and baby are healthy, that's the most important thing. Right. So again, it's just case by case basis. Both are safe. Even if you are a candidate for a vaginal delivery, but you opt for a C-section, that is your business. Nobody should make any woman feel like less of a mother for having a C-section, because at the end of the day, you gave birth to that baby. You carried that baby for 9 months. And trust you me, having a C-section is no walk in the park. But at the end of the day, if that's how my babies are going to get here safely, I'd have 100 C-sections.
Right. Wow, thank you so much for that advice. And so we're about to round up our conversation. And, my story is exclusive to me, like I said, and I'm sure you must have dealt with all kinds of people, women with different stories and stuff like that. And I mean, even though I was going through all of this, I still kept a smile on my face. I was still hopeful. Like I said, a lot of people didn't really understand what I was going through. And, you have all this small talk, especially in our community. You have all these people making insensitive remarks and stuff like that. So from your experience, especially on what you have seen women go through for all these years, what will you advise our community about in regards to, just approaching young women or men struggling with fertility issues in general?
Give people grace, because you don't know what they're going through. You don't know why they're dealing with what they're dealing with and how it's affecting them mentally and physically. And so just give people grace. Give them the support that they need. Don't give unsolicited advice, and just be there for them.
Yeah. Yeah, that's very true. Well, thank you so much, Dr. Ekwo. It's always a pleasure speaking with you. And it was an honor to share my story. Thank you. It was an honor to share my story with you. And thank you for giving all this helpful insight. I hope that, this conversation can also encourage other women who have gone through a similar experience to know that they're not alone and that there's always a rainbow at the end of every storm. And I just hope that we can be more sensitive to one another as a community as a whole. And I hope that this will also motivate other women to share their stories, whether with me or within their circles. But hopefully it definitely sparks a conversation and let us know that, people go through so much behind the scenes that we know nothing about. And like you said, to offer our people grace. So thank you so much. And I'll definitely thank you. And I'll definitely put your contact information in the show notes. We already had that in the previous episode. So I just want to thank you for taking that time to speak with me today, and I will catch you in the next episode.
Absolutely.
Thank you. Bye.
You're welcome. Bye.
That's it for today. Thank you for listening to our show. If you want to participate in the show or find out more helpful resources, then visit www.livingafricanpodcast.com for more information or email us at hello@livingafricanpodcast.com. Also, don't forget to connect with us on all social media platforms at Living African Podcast. You can also connect with Anyo directly on Facebook or Instagram at Anyo Farmbard. Thanks again for listening, and let's not forget to be more understanding and nicer to one another.